Hello, I am Dr. Tin. Welcome to this lecture about recurrent abdominal pain in children. First of all, I would like to give you a case scenario of a girl with recurrent abdominal pain. A 10-year-old girl presented with a 6-month history of central colicky abdominal pain lasting 15 to 30 minutes. It occurred mainly before breakfast and sometimes at school. She had the pain 2 to 3 times per week. It was worse when she had exams in school. There were no associated factors such as fever, nausea, vomiting, altered bowel habits or urinary symptoms. There was no family history of inflammatory bowel diseases, peptic ulcer disease or migraine. She was happy at home and had many friends at school. There was no history of bullying or peer pressures on her. Physical examination was normal. What is the most likely cause of her abdominal pain? What are the features in her history that support this diagnosis? How will you manage her? Now, I am going to discuss recurrent abdominal pain in children and how to tackle this problem. Learning objectives. At the end of this lecture, students should be able to define recurrent abdominal pain, note the causes, note the approach to get the diagnosis, manage common non-organic causes of abdominal pain. Recurrent abdominal pain is defined as pain which is sufficient to interrupt normal daily activities and lasts for at least 3 months. Up to 10% of school-age children face this problem in their life. In more than 90% of these cases, we can't find any organic cause. Other causes include gastrointestinal, hepatobiliary and pancreatic, urinary tract, gynaecological, and psychological problems. In a small minority of cases, psychosocial factors such as bullying, abuse and stress either at home or at school may be the cause of recurrent abdominal pain. Gastrointestinal causes include irritable bowel syndrome, chronic constipation, functional dyspepsia, abdominal migraine, dietary intolerance such as lactose, gastroesophageal reflux, gastritis and peptic ulceration, inflammatory bowel diseases, celiac disease, parasitic infection. Hepatobiliary and pancreatic causes include hepatitis, chronic pancreatitis, gallbladder stones. Urinary tract causes are urinary tract infection, pelvic-ureteric junction obstruction, urinary calculi. In adolescent girls, we need to consider gynaecological causes, such as dysmenorrhea, ovarian cysts or pelvic inflammatory diseases. A detailed history taking is essential to rule out organic causes. First of all, we should ask details of abdominal pain, gastrointestinal and urinary symptoms. Other symptoms such as fever, skin rashes, arthritis and weight loss are also important, since these are the extraintestinal manifestations of chronic inflammatory bowel diseases. When taking the pain history, firstly we need to find out the site of the pain. The further the site of maximal pain is from the umbilicus, the greater the likelihood of organic diseases. Character of the pain is also important. For example, colicky pain is most likely due to intestinal obstruction or any obstructions in biliary or urinary tract. We also need to assess the severity of the pain in order to find out how much it interferes with the child's daily activities and whether he or she has been missing schools because of the pain. Does the pain radiate anywhere? For example, if pain radiates to the back and is associated with severe vomiting, then pancreatitis is the possible cause. Is there anything that relieves the pain? If pain resolves after meals and wakes the child up from sleep, then it is likely due to peptic ulcer disease. Finally, aggravating factors should also be elicited. We need to ask about gastrointestinal symptoms including loss of appetite, nausea, vomiting, altered bowel habits, presence of blood in stool, jaundice, and abdominal distension. These histories may give clue to the causes of abdominal pain. For example, loss of appetite with chronic diarrhea and bloody stools are symptoms of chronic inflammatory bowel diseases. Bile-stained vomiting, Constipation and abdominal distension are suggestive of intestinal obstruction. Child with liver and biliary tract problems may present with jaundice. Constipation may lead to recurrent abdominal pain as well. Urinary symptoms such as pain during micturition or dysuria, increased frequency of passing urine, urgency to micturate, and presence of urinary incontinence or bedwetting in previously toilet-trained child, should also be asked to rule out urinary tract problems. Past medical and surgical histories may be related with the current problem. For example, if the child had previous abdominal surgery, the recurrent abdominal pain can be due to intermittent abdominal obstruction secondary to presence of adhesion. In adolescent girls, menstrual symptoms such as pain during periods, any irregularities of periods, and massive bleedings with suprapubic pain should also be asked. In children with lactose intolerance or malabsorption syndrome, excessive amounts of lactose in the child's diet can lead to malabsorption resulting in abdominal pain with diarrhea. Prolonged or frequent taking of non-steroidal anti-inflammatory agents, for example ibuprofen, can cause drug-induced gastritis. Family history of inflammatory bowel diseases, peptic ulcer diseases and celiac diseases should be asked. Presence of stressors either at home or in school such as parental conflict, concerns regarding academic achievement, peer relationships, bullying, and substance abuse, needs to be explored because these are factors which may lead to somatic symptoms of abdominal pain in children. First of all, we need to perform general physical examination. We need to plot the weight and height of the child on growth chart. Pubertal status should be checked. Then we need to examine if there is any allergy, jaundice, mouth ulcers, clubbing of fingers, arthritis, or skin rashes such as erythema nodosum. Allergy, clubbing, skin rashes, mouth ulcers, growth failure and delayed puberty are clues for organic diseases, for example, chronic inflammatory bowel diseases. Presence of clubbing with jaundice suggests the presence of hepatobiliary problems. After general examination, we need to examine the abdomen to find out if there are any areas of tenderness, palpable masses and organomegaly such as hepatosplenomegaly or palatable kidney. Perianal areas should be examined to look for fissures, fistulas or skin tags. Examinations on cardiovascular, respiratory, musculoskeletal and central nervous systems should also be performed to ensure that there is no other underlying disorders which can be associated with abdominal pain. The following are red flags for recurrent abdominal pain in children. In the history, if the child has symptoms such as waking up at night due to pain, recurrent fever, skin rashes, mouth ulcers, recurrent vomiting, chronic diarrhea, weight loss, arthritis, family history of inflammatory bowel diseases, peptic ulcers and celiac diseases, then the recurrent abdominal pain is likely due to an organic cause. Similarly, if clinical examinations revealed allergy, impaired growth, delayed puberty, presence of rebound tenderness in the abdomen, abdominal distension, hepatosplenomegaly, other palpable abdominal masses, anal fissures or fistula, perianal skin tags, occult blood in stool, then we have to think of organic causes rather than functional ones. The investigations that need to be sent in a child with recurrent abdominal pain depends on the provisional and differential diagnosis. After a thorough history taking and physical examination have been performed, if there is no pointer towards any organic causes, it is reasonable to do some basic investigations, such as full blood count, erythrocytes sedimentation rate, urinalysis and urine culture, and stool examinations. The presence of anemia, thrombocytoses or elevated ESR may indicate chronic inflammatory bowel diseases. Urinalysis and urine culture should be sent to rule out urinary tract infection. Growth of bacteria, presence of ova, cysts or parasites in stool indicate gastrointestinal tract infections. Now I am going to discuss more about the common functional abdominal disorders. These are irritable bowel syndrome, functional abdominal pain, abdominal migraine, and functional dyspepsia. In irritable bowel syndrome, patient suffers altered gastrointestinal motility and abnormal sensation following intra-abdominal events, for example, after a gastrointestinal infection. They may have positive family history of similar problems. There is a characteristic set of symptoms which include periumbilical pain which is worse before or relieved by defecation, stool pattern which are explosive and mucousy with fluctuation between diarrhea and constipation, feeling of incomplete defecation, and bloating. In functional abdominal pain, the children suffer from pain around the umbilicus. It is not associated with eating or defecation. It is more common in those who have anxiety and perfectionism. Although the pain is worse at the start of the school day and before returning to school after vacations, they enjoy going to school. This is in contrast with school phobia in which the children are reluctant to go to school. Now I am going to discuss abdominal migraine. In this condition, the pain is periumbilical or poorly localized. It is associated with headaches, anorexia, nausea, vomiting and facial pallor. There is a family history of migraine. Children with abdominal migraine may improve with anti-migraine drugs such as pizolidine. The diagnosis of functional dyspepsia should be considered in children with upper abdominal pain. They have non-specific symptoms such as early satiety, bloating, and postprandial vomiting. All investigations for peptic ulcer diseases, for example, serological test of Helicobacter pylori and upper GI endoscopy are normal. And the children respond poorly to treatment of peptic ulcer disease. The aims of management for children with recurrent abdominal pain are to rule out any serious cause without unnecessary investigations, and to provide reassurance to the children and parents once organic causes have been ruled out. So successful management depends on an accurate diagnosis. Children with functional abdominal disorders should resume their daily activities and go back to school as early as possible. If the child suffers pain at school, he or she should not be sent home from school with pain, but need to take a short break until the cramping pain abates. The pain diary must be kept by the child with parental assistance. This is to ascertain the frequency, duration and other associated symptoms. High-fiber diet may be helpful for irritable bowel syndrome. Cognitive behavioral therapy can be given in severe and persistent cases. Half of children become free of symptoms within 6 weeks of cognitive behavioral therapy. Some children take some time to recover. It depends on prognostic indicators including gender, age of onset, family history of chronic pain, duration of pain before treatment. Children who are girls, whose symptoms started after 6 years of age, with no family history of similar problems, and has less than 6-month duration of symptoms before treatment, have better prognosis. In summary, most children with recurrent abdominal pain have functional abdominal disorders. Detailed history, proper physical examinations with basic screening investigations are sufficient to exclude organic pathology in them. In these children, their symptoms are vague with no red flags in history and physical examinations. The results of their initial investigations are normal. Therefore, subsequent invasive tests are not needed. Reassurance with behavioral therapy is the mainstay of management. These are the references. Thank you for your kind attention till the end of the lecture. I hope you would enjoy to learn